Good evening and welcome to this webinar on the gut microbiota. Thank Dr.Reddy and Mr. Kannan for inviting us here. This session was supposed to have been chaired by Professor Gauradas Chowdhury, whom all of you know. Gaur, unfortunately, has been held up due to a professional commitment. He'll join us a bit later. Now, these two talks today, they follow one after the other. And the first talk is about the unique features of the Indian gut microbiota. To speak on this, we have Dr. Rupjyoti Talukdar, very talented gastroenterologist from the Asian Institute of Gastroenterology. He is a Wellcome Trust DBT India Alliance Fellow, and he's done a lot of work on the gut microbiome. So, Rup, the floor is yours, Doc.
Thank you, sir, for that kind introduction. And let me thank, to begin with, to DRL and Kannan for this wonderful meeting, for organizing this and inviting us. And my job today would be to speak on the Indian gut microbiota. Is it unique? And before going to the Indian gut microbiota proper, let me take you through a little journey on how microbiota science developed, what the microbiota actually is. So if we go to any departmental store, be it in India, be it abroad, you'll see lots of things like this: men's probiotic, love bugs. I mean, all sorts of preparations should be there for kids. And the goal of all this is to maintain health. That's what they would claim. And then we have many probiotics from different pharmaceuticals that have come up and that has been used or indicated or prescribed with a therapeutic intent. Then this is another evolving science or evolving modality of fecal microbial transplantation that is used to treat several diseases. But what is the basic target of these? The basic target of all these modalities are the gut microbiota. All of these directly or indirectly try to modify the microbiota or improve the microbiota. So what is the microbiota to begin with? So by definition, the gut microbiota or the microbiota can be defined as the entire population of microorganisms that colonize a particular location. It can be anywhere in the body, the gut, skin, eyes. It can be anywhere in the environment, the trees, the leaves, the soil, your study table, the glass where you drink water. And by and large, invariably, when we talk about microbiota, usually people understand it as the bacteria. But if we look carefully, or if we go deep into it, actually it's an ecology of all the different organisms, right from bacteria, fungus, protozoans, virus, and the archaea. And in fact, it would be interesting to know that our bodies are most predominantly inhabited by the virus, the virome. But because of the difficulties in studying virome, because of the technological advance have not yet reached that far to study virome with great meticulousness, this is not studied much. Now more and more studies on the fungome have come up, and what we discuss more, and if you see the literature, most of the papers would deal with the bacteriome. And today's talk will also deal mostly with the bacteriome, a component of the microbiota. So what does the microbiota do in the human body? It has several functions, and one of the most important function would be the metabolic function, where it secretes or produces several acids called short-chain fatty acids that have significant implication in the host metabolism in health promoting effect. I'll just come to this in a moment. The gut microbiota is very essential in maintaining the gut barrier integrity. They produce lots of gap junction proteins that bind the intestinal and cells and maintain the barrier. It has a significant role in immunomodulation. Whatever we all know from our knowledge of inflammatory bowel disease, the gut immunity, the intestinal microbiota has a huge role in maintaining that immunity, and alteration in the gut microbiota can lead to alteration in the immunity, and which could be one of the factors that leads to IBD. And of course, the microbiota leads to metabolism of several drugs, including anti-cancer drug, digoxin, and several others. So if we take a quick look at the metabolic function, So the microbiota ferments undigestible carbohydrates, especially these organisms, as a result of which they produce several short-chain fatty acids, mostly butyrate, which is health promoting, which is good for the health. If the bacterium is altered, or if we have a bad gut bacteria, it will be more of propionate, which is not good for health, or which should be implicated in several disease pathogenesis. It helps in protein digestion. It puts in K. And the microbiota, the healthy microbiota, also synthesizes conjugated linoleic acid, which have anti-diabetic, anti-atherogenic, anti-obesogenic, hypolipidemic, and immunomodulatory properties. So these organisms would lead to all the health-promoting action by the conjugated linolenic acid, short-chain fatty acid, and then they also cause breakdown of polyphenols. So where did the microbiota come from? So let me take you back to evolution. So when billions and billions of years ago, when the life first originated in Earth, it was the bacteria. So since then, the bacteria started evolving and it got embedded in all life forms till we reached the most highest life form, the human beings. And then when these human beings evolved in Africa, which is the most commonly believed hypothesis, and then they started migrating all throughout the world. And initially there was something called Pangea. All the continents were stuck together, and then with time they were separated. So with this evolution, there was formation of different society, more of agrarian society, and that constituted a very complex network or ecology, or a complex environment, including the bacteria, the early human beings, and which was affected by the flora and fauna around them. So this is how the microbiota evolved over billions of years, and the bacteria or the bacterium is still evolving. And that is what it makes us. Even though we boast ourselves to be the humans, the highest life form, actually we are just 10% humans and 90% bacteria. And there are over 100 trillions of bacterial cells all over the body. And if we talk about the gut, there are over 1,000 different species within the intestinal tract, from the mouth, oral cavity to the anal canal. And majority of the species within the human body are actually constituted by 30 to 40 of these 1,000 species. And if we look at the genome, if we see the genome of the microbial genes of the microbes, the length of the genome is 150 times more than the actual human genome that we have. So if we look into our intestine, and if we move from the esophagus to the colon, there will be an increase in the number of organisms based on the pH. As we go down, the pH changes, and again, you'd be surprised to know that even the stomach, which is supposed to be sterile, contains a host of bacteria, not only Helicobacter pylori. And it is important to understand that a good balance of all these bacteria is important to render Helicobacter pylori non-infective or non-pathogenic. If this group of organisms gets altered, that could make Helicobacter pylori infective or pathogenic organism. And if we look at the microbiota, over 70% of the whole microbiota in the body is residing in the colon. And this have actually several implications. So this could be one of the reasons why most of the scientists use colon as, or the stool, as a source to study gut microbiota. And then it could also have lots of implications in inflammatory bowel diseases. So if we look at the diversity, if we look at the level of individual human population, so these are complicated diagrams. You don't have to put your mind in what these are. So this just shows the group of organisms in different human populations. So this is at a single species level, but if we look at the whole population level, including the different species, it appears that there is overlap of the microorganisms across different species, including humans, primates, and even lower animals, which indicates that these organisms have been evolving and have been having a close relationship with the ecology or with the environment, and they acquire these organisms, or they share these organisms between different species. And if we look at the diversity of the microbiota over time, so So this is a very elegant study published a few years back, and many of you must have heard the name Udzi. Udzi is the name of this person who has been, like, it's a computer simulation of this skeleton. So what happens once like a group of mountaineers who were climbing the Swiss Alps, they found this mummy, the skeleton, and they thought someone must have fell down from the Alps, from the cliff, and might have died. But when this was subjected to examination and when they did carbon dating, it turns out that this was a mummy which is 4,000 years old. So they gave the name Udzi. And this was a very rich resource to see or to study several parameters of life, including the microbiota. Microbiota can also be studied from coprolites. These are fossilized stool remains from ancient civilizations, people from ancient civilizations. So this is a coprolite from 8,000 year old time point. Again, this is a mummy of a soldier who died during the Second World War and was buried in the snow. So this study included all this kind of patients, all this kind of samples, and also samples from 1400 years back or 1600 years back from different American and South American sites. And if you see this, again, this is called a principal component analysis, which tells you the closeness of the organism. So if you concentrate on this diagram, what we see here is this is the modern human microbiome. So this was very similar to the ancient microbiomes, both humans and non-human primates, which indicates that there is several similarity, or the microbiome to a certain extent is conserved. But if you see here, the similarity of the ancient microbiome was much more with the modern civilization who were rural based. People who were from the urban areas, the similarity was not there, which again sends out a strong signal that it is most likely the modernization or urbanization has an impact that is changing the microbiome, or that is making the microbiome to evolve. So what determines the gut microbiota? Again, if we look temporally from birth to old age and death, so the initial microbiome in the infant is largely determined by the maternal microbiome, so the mode of delivery and the early feed. So if a child is born out of normal vaginal delivery, they will have more of a normal microbiota, the lactobacillus. And this is the beauty of nature. So the baby would require lactose to digest the milk from mother, so they will have lactobacillus. But if a baby is born out of cesarean section, they will have more of the skin microbiota, streptococcus or others. And the babies who would be taking formula feeds, they will have a different set of microbiota. And that's how there have been several recent studies which have ascribed allergic disorders, atopic disorders with cesarean section or formula feed. So there will be a transition zone at the age of around 3 years, at which almost 70% of the adult microbiome is acquired. And then from childhood to old age, it's very dynamic. There could be a core microbiota which is static, but several other factors makes it dynamic, like the diet patterns of the people, how they have been taking their food. Is it meat-based, carbohydrate-based? Are they taking lots of polyphenols, seaweeds, and of course taking processed food? So is this how the way the people are taking processed food, food containing emulsifiers, they could determine the microbiota over across life. And then geography, antibiotic use, biodiversity, microbes in other locations, which is also important. The gut microbiome has a close crosstalk with microbes in the skin, microbes in other places, in the genital tract, in the urogenital tract. So there is close crosstalk between the gut microbiota and the microbiome in the other places. So if a person has a disease in another location of the body, for example, UTI, that can still affect also the intestinal microbiota. And something that is, again, I think has importance or relevance to the Indian context is parasites. Parasites have also been shown to impact the gut microbiota. There is an Indian study from northern part of India, I think Dr. Vinita Huja is also involved in that, which showed that with a change in the parasites, so it's a change in the amoebiasis. The asymptomatic cyst pusser had a different kind of microbiota compared to those who do not have cyst in the intestine. So then why do you at all have to study the Indian gut microbiota? So if we see this map of India, you can see different color patterns. So these are the biodiversity hotspots. So India has 4 biodiversity hotspots: the Himalayan region, the Indo-Burmese, which includes Sikkim and the northeastern region, the Sunda lands, which includes the Andaman Nicobar, the part of the Chilka Lake and the Sundarbans and the Western Ghats. And why do I call it a hotspot? Because this areas have a very, very rich resource of biodiversity, very rich flora and fauna, which are endangered. So it is possible that over the next 50 years, the microbiota in this area could change and we could see a totally different microbiota. So it becomes logical to have a blueprint of the original microbiota, which could form a reference for all future studies. But more importantly, the Indian subcontinent is inhabited or is characterized by such a large population. So this is India's population today at 10 a.m. I just picked down it from the internet while I was making my slides. And if we see several tribal population, different culture, different food, different flora and fauna, so it's likely or it's logical to think that the microbiome in the Indian subcontinent would be diverse and might be different from the other area. Then we now see more and more of interstate and intrastate migration. These are the 2 migration maps of India, which means that there is lots of mixing of society, socio-cultural mixing is there, dietary changes is happening very frequently. And then we are all aware of development of technology. As technology is developing, the gadgets are becoming smaller and our sizes are becoming bigger, which means that obesity could be impacting, or the other way around, the microbiota can be impacting the obesity. And we are all participating very strongly in the advent of the fast food culture. And that again is likely to change the microbiota. So that makes it very important to look at the Indian gut microbiota and see what it is now, so that we understand several current diseases and so that we understand what could be happening in the future. So, in fact, the first study on the Indian healthy microbiota came from Dr. Ramakrishna's group that was published around 12 years back in the American Journal of Clinical Nutrition. And I would say this was a very elegant study where they looked at the fecal microbiota in childhood and followed them through adolescence. And that was a molecular study. And why this is commendable, at that time, this technology of like next generation sequencing was not there. So they had to take all the pain of doing the study based on polymerase chain reaction. So that's why I consider this is the beginning of the microbiota research in India, and with this elegant study. So following this study, there had been several studies that have come up in the literature till recently. And this is a long list. You don't have to go through the whole of the list. It's a busy slide, but suffice it to say, all these studies use different technology. All these studies were done in different geographic areas of India. But my importance, or the importance that I put here, is the sample size. So usually for this kind of microgenome or metagenomic studies, we need a big sample size. And of these, only 4 studies had decent sample size. So when these studies were being published, we started thinking in our group, like since there has been so much of development and there has been change in the socioeconomic strata, so why don't we look at the tribal microbiota, because that could represent more normal microbiota who in this tribal populations who have been away from the modernization. And that's where our study came in, and we had studied 15 tribes across eastern India and southern India, from Telangana and all over the northeastern part, including Sikkim. And the people had a Mongoloid or Proto-Australoid ethnicity, young age, and there were 92 males. And we used 2 different technology to look at the microbiota. And so when we collated our results with all other studies, so this is a review that has just been accepted in the Indian Journal of Gastroenterology on the Indian gut microbiota. I mean, it will come online probably in a couple of weeks. So what we did here, we collated all the data on Indian microbiota and tried to see what was there. And this is a busy slide. So the summary was, what we found was, so this Venn diagram depicts the microbiota from the different studies, but what stands out in the center is there are 4 organisms: Prevotella, Faecalibacterium, Roseburia, and Bacteroides. So these are the core Indian microbiota. So these constitute the most predominant microbiota in the Indian population. There were also changes in metabolites. There were differences in the metabolites, but I won't go into there in this talk because of the vastness and the complexity, and of course also the lack of time. So you can always go to this article and you'll find all the information in there. So if you remember that table, those individual studies were based on, were done in different regions. The populations were different, and yet all studies try to say that this is the Indian microbiota, which I think would be an ideal study, is to see the microbiota in a pan-India pattern for patients, individuals from all over India, large sample size, same technology to detect the microbiota, same bioinformatic analysis. And I think this is that ideal study that was published in 2018. The sample size was pretty big, 1004. That was a factorial design where the authors took into consideration the geographic location, the body mass index, obesity, physical activity, age, and it constituted, it was done across 14 centers across India. And I'm glad that they also included Guwahati, the city from which I come from. So there were 4 centers from north, 3 from east, 4 from west, and 3 from the south. So what did they find? There were 993, nearly 1,000 unique microorganisms, of which 390 were common across all the geographic location. But what is intriguing was there were 36 unique organisms to North India, 149 to South India, 95 to West India, and 62 to East India. What does it mean? This could be determined as the common microorganisms, but the different the unique microorganisms in these different locations could indicate that there is something in that region which is determining this microbiota. And that is the importance of this study. And that could have implications in therapeutics or understanding diseases locally. So overall, Prevotella copri and Faecalibacterium prosnitziae were the most predominant seen in all the population. And this was same as what we found in our review. So since this came from a pan-India basis, we can call that Prevotella copri and Faecalibacterium prosnitziae are the core Indian gut microbiota. And both of these are health promoting. These are seen mostly in the people having a vegan diet, and these are responsible for production of lots of butyric acid and maintaining the gut barrier and promoting the gut mucosal immunity. Now, are these different from the West or other population? Again, this study shows, again, we need not go into the details of this, but these, if you see the colors, this is Indian, this is American, and these are the genus, written here, the legend. So there are significant differences in the relative abundance or the proportion of these different genera in the Indian population compared to the American population. And when we looked at our study on tribals, if you see here, this red dot indicates the Indian tribal population. So this was very close only to the Mongolian tribal populations. It was different from all the other Amerindian or Hadza or Malawian populations. So again, it indicates that there is some commonality between the Indian and Mongol. And probably there could have been some genetic link between the two populations that maintains the commonality in these two groups. So then this is another study that was published more recently. Again, it looks complicated, but if you see, just see the color codes and you'll see the slices, size of the slices are different in India, are different from many of these slices from the other population across the world. For example, from Africa, from America, from Northern Europe, from China. So this also indicates that the Indian gut microbiota are different from the other world population. So then what determines our microbiota? This I have collated from different studies. So it's likely that in India, because of the diet, overall, it's more of a carbohydrate and fiber-rich diet. all across India, which could lead to predominance of Prevotella, which forms the core organism. And the secondest population in our study, they had more of milk-based products that leads to more of Lactobacillus and Bifidobacterium. Manipur and Sikkim, the Bhutia population, they are more used to fermented food, so that population had more of bacteroids. Urban, the study is from Bhute in Pune, who studied the microbiota in Pune and Delhi, both urban and rural. So the urban population had low Faecalibacterium, the rural population had a higher Faecalibacterium. Again, I already talked about altitude. Probably this is because of diet. And of course, the genes. So the Nepali population and the Thai Patke population had very close similarity to Mongolians, and these have Mongoloid descent. So probably the genetics is determining the genes or commonality between the Mongolian and the Northeast Indian microbiota. So I think I have 3 or 4 more slides left. So having said so, we now know that the microbiota in the Indian population is different from the West, and even within India, there is a diversity of the microbiome, which could be affected by the lifestyle, could be affected by the diet, the genes, or urbanization, and that brings me to this important question. So, can we have a single or one type of gut microbial modulation strategy to maintain a good microbiota in this population? Or should it be customized or personalized more to the individual groups of population who has different microbiota? So it's an important question. I think in the years to come, more research will shed light on that. But as of now, whatever resources we have, how do we keep our microbiota healthy? Just taking lots of vegetable-based diet. There are several studies which shows that colored or vegetable-based diet results in richness, higher diversity, higher abundance of the good bacteria. And this was a very elegant study, which was done where the authors had compared the microbiota from children in Burkina Faso, a small country in Africa, and European children who had a meat-based diet. And there was significant difference between the two populations. The Burkina Faso children had a more of health-promoting bacteria, Faecalibacterium predominant, Firmicutes predominant compared to the European Union children. Then it's important to understand that emulsified food, the fast food, has preservatives and emulsifiers, especially carboxymethyl cellulose, polysorbate 80, and it was published in a very elegant paper in Gut a few years back that these preservatives could be an important factor in the fast food, which could affect your microbiota, so it's better to avoid. And one of my biggest concern, and many of you would agree to that, antibiotic use. Like antibiotic use have shown that there could be significant change in the microbiota, which can live up to a long time, and many of the organisms do not recover. And there is always a risk of horizontal gene transfer by this antibiotic resistance. So it's very important to use antibiotics with care, with a sense of responsibility. And I think in the Indian context currently, this is the most important factor that could cause change. So finally, ladies and gentlemen, coming to the summary, the gut microbiota has co-evolved with human civilization, and the microbiota is dynamic. It maintains a symbiotic relationship with host metabolism. And as I have showed all across my talk, the Indian microbiota is unique. It's different from the West, and it's also having lots of diversity within India. And probably the future could be such that we can use the microbial fingerprint to assess the health status. Gut microbial manipulation could have a therapeutic role, and I think that days of designer probiotics or precision probiotics are coming, in which we could target probiotics to specific group of individuals. So finally, I'd like to acknowledge several people, especially these people who had worked on the microbiome studies in collaboration with me. And thank you. I think it's important for us to understand our ecology, the ecology of the human microbiota and the entire.
Thank you very much, Rupjyoti. Sorry I wasn't here, but I tell you, this was a very elegant paper and very elegant presentation, because we are normally used to listening what is kind of pre-digested in the West, and then giving it as a part of talks here. But I'm so happy that you presented very Indian data. And this is something very unique for, I'm sure, most of our audience. So a big hearty congratulations. I wish we could clap, but it wouldn't be audible.
Thank you so much, sir.
But you can understand that that's all of us would want to do. I would now like to go on to Dr. Ramakrishna.
Thank you.
And one of the reasons why I actually offered to join in is because Ramakrishna is a person whom I have always admired. He's one of the best researchers in India. And this is a field where he has contributed immensely, making India very proud. And as you very rightly started off quoting a seminal paper from Dr. Ramakrishna, he's actually been a very active researcher in this field. And we are indeed very keen to listen to Dr. Ramakrishna to tell us about, given the complexity of the gut microbiota, how do you say what is normal and what is abnormal? I think that is a very million-dollar question because the variety itself is so immense. For those of you who don't know Dr. Ramakrishna, he was the professor and head of gastroenterology at CMC Vellore before he retired. Now he's in Madras. He works in an institute as a director. Same is the institute. So Dr. Rama, people know you more by your research and your fame rather than by the institute that you belong to. Over to you.
Thank you very much. Thank you for that very nice introduction, very flowery. Thank you so much. So we need to go on to the next part of the talk. And what I was asked to speak about is actually strategies for managing dysbiosis. So in the course of this, what I thought we could do, and Rup has set the stage for this. He's told you what is normal and what we can expect in India versus, say, the West. So what is dysbiosis is something that we'll explore as we go along. I'll tell you a little bit about the strategies for dysbiosis. Actually, many of them are actually really fairly obvious. Whether they work is something that we'll need to think about. So we heard about functions of the gut microbiome in health. Carbohydrate fermentation is a major function. So short-chain fatty acid production is a result of that. Protein fermentation is something which happens, and this is one of the bad functions of the gut microbiota because this results in a lot of noxious molecules which the body has to get rid of. And then there are effects on the host immune status. What is coming into prominence now is that the gut microbiota are important in controlling glucose metabolism. And as gastroenterologists who every day treat buckets of patients with IBS, we know that the microbiome has a huge influence on the brain. So the gut-brain signaling is largely microbial in origin. So let's look at what is eubiosis. Eubiosis just means that there is a balance between the good microbes and the bad microbes. And here I've listed what we currently understand to be good microbes. On the left here, on the protective side, you have lactobacillus species, bifidobacterium, Saccharomyces Boulardii, E. coli Nissel 1918, Clostridial clusters 4 and 14, Roseburia, Faecalibacterium prausticea, all of which Rup talked about, all of which are really carbohydrate fermenters. And then there's Bacteroides theta iota micron, which has a lot of immunological effects, and Akkermansia, which has metabolic effects. And on the aggressive side, we have adherent invasive E. coli, Klebsiella pneumoniae, Fusobacterium, and so on. And when this balance is disturbed, and the bad guys become more or the good guys become less in number, then you have a tilt towards an inflammatory microbiome, and this is what is called dysbiosis. So I'll just draw your attention to a recent review in the BMJ, where all these things here on the left side, which are disease characterized by dysbiosis, These factors here are all factors which contribute to dysbiosis. But our goal is really to move the person from this stage to a stage of health. And some of the good things that we can give them are here, and the good outcomes are listed here. I'm not going to go into this in detail. Now, the champion of eubiosis and dysbiosis was a gentleman called Ilya Mechnikov, Russian in origin. He was director of the Pasteur Institute in Paris, and he won the Nobel Prize for discovering phagocytosis. Now, phagocytosis is the father of innate immunity. So that is the very thing from which we understood innate immunity. But innate immunity, our knowledge came 25 years ago. Mechnikov discovered phagocytosis in 1906, or he got the Nobel Prize in 1906. But what Mechnikov also said was that old age and natural death is due to auto-intoxication produced by putrefactive microbes in the colon. And he got these ideas by observing people in various areas, especially people living in Bulgaria in the mountains. And these people consumed a lot of yogurt, and they lived to well beyond 100. And so he thought that their healthy lifestyle was responsible for their living to a much older age and healthy lives. Now, dysbiosis is something that happens in a lot of diseases. And here I have chosen to show here a few representations from our own work in a number of conditions which affect our health. Here's acute diarrhea, colon cancer, obesity. Obesity, for instance, there's an increase in Faecalibacterium prosnitzeae. And although Rup told you this is a good bacterium, here what Faecalibacterium prosnitzeae does is to eat up all the unabsorbed carbohydrate that enters our colon and gives more energy to the body. And so in certain conditions, too much of a good thing is also not good. And in particular, inflammatory bowel disease, with which I'm very much fascinated, we know that certain bacteria are altered. Here's something called Clostridium leptum, which produces short-chain fatty acids. The diversity of Clostridium leptum is lost in Crohn's disease. In other words, if you take Clostridium leptum in a healthy person, you will find 5, 6, 7 different strains. Each of these bright zones tell you that's a different strain. And when you take a person with inflammatory bowel disease, you find that the diversity is much reduced, that the number of strains of Clostridium leptum they have is less. And this reduced diversity is shown in these indices here. So we've looked at mucosa-associated microbiota. Now, it's not just the stool microbiota which are important, but also those which stick to the mucosa. And here, when you look at the mucosa, we heard Rup talk about Firmicutes, which are good bacteria. We know that Bacteroidetes are really bad bacteria. In health, Firmicutes outnumber Bacteroidetes considerably. But in inflammatory bowel disease, Firmicutes becomes less, Bacteroidetes becomes more, so the ratio changes. That's dysbiosis. So how do we reverse dysbiosis? So one of the things that I haven't mentioned and I haven't got it on my slides is dysbiosis can be not only a change in the ratios, but even if there's small intestinal bacterial overgrowth, where normally there should not be too many bacteria, if the number of bacteria becomes more, you could even call that dysbiosis. So over the last century or the last 1.5 centuries, people have taken various approaches to reversing dysbiosis. Firstly, they did colectomies. Then came colon cleansing. Once we got into the antibiotic era, there were antibiotics. Then came prebiotics, which are basically carbohydrates, which stimulate good bacteria. And then there were probiotics. And now, of course, we are in the era of fecal transplantation. So let's look at a death certificate from 1923, where the cause of death was auto-intoxication for a long period of time. And this gentleman here in the UK became Sir William Arbuthnot Lane. What is distinction? His distinction was the maximum number of colectomies for auto-intoxication. Hopefully we don't do these things anymore. And here is an ad from the 1940s in the US for treatment of auto-intoxication. If you feel depressed, tired all the time, sleep does not refresh you, doesn't this sound like a lot of our IBS patients? Now these people will have something to help them. The real McCoy was going to help them. And here is a picture of a board that used to be on the street behind the hospital where I practice, colon hydrotherapy as a treatment for dysbiosis, cleaning treatment. And a variety of illnesses are treated here using imported equipment and administered by reputed doctors. So that's the next way to go. And that's imported equipment that is doing the reversing dysbiosis. So what Mechnikov also said was, what is the cure for dysbiosis? You have to replace these putrefactive microbes with a healthy flora of lactic acid bacteria. And so thus began the science of probiotics. So just draw your attention to a World Gastroenterology Organization publication called on Guidelines on Probiotics and Prebiotics. I was one of the authors. Essentially, what I'm going to sum up in the next couple of slides derives from this. So prebiotics are dietary substances, mostly carbohydrates, which selectively favor the growth of beneficial bacteria. And the examples are fructooligosaccharides, galactooligosaccharides, inulin, and lactulose. Most of you use lactulose all the time. Fructooligosaccharides are commercially available and we do use it sometimes. It's used actually in a lot of the feeds to add fiber, soluble fiber. Now, prebiotics are equivalent to aminosalicylate in maintaining remission in ulcerative colitis. But they are not beneficial in induction of remission and they are not beneficial in Crohn's disease. There is some evidence that prebiotics are useful in the prevention of colon cancer in specific situations. And obviously we use prebiotics, lactulose, in preventing hepatic encephalopathy. What about probiotics to treat dysbiosis? And here I've given you the level of efficacy as we have summarized in our WGO guidelines. So these are conditions where there is good efficacy. That is preventing antibiotic-associated diarrhea, preventing C. difficile diarrhea, inducing remission in pouchitis, and maintaining remission in pouchitis. There is modest efficacy when you try to induce remission in mild to moderate UC. One of the major studies which goes along with this came from Dr. Sood and Vinita Huja. It's a multi-center study. Maintaining remission in UC, there's a modest effect. Treating acute diarrhea, there's a modest effect. Some degree of efficacy in preventing symptoms during triple therapy of H. pylori, and some degree of efficacy in IBS. What about fecal microbiota transplant? So this is the consensus of opinion when you look at it all through. So the main utility is in recurrent Clostridium difficile infection. 8 randomized controlled trials, more than 500 patients, and the risk of getting recurrent CDI is reduced by 62%. Relative risk is 0.38. What about active ulcerative colitis? So induction of remission in active ulcerative colitis, in severe ulcerative colitis and steroid-resistant UC. 4 studies, 277 participants, and there is a 20% reduction in the risk of remaining steroid dependent. In IBS, on the other hand, 4 RCTs, nearly 120 patients, you see the confidence interval span 1, therefore it is not effective. So definitely in C. difficile infections, useful. In UC, to a lesser extent, active UC, it's possibly useful. Now, what about dysbiosis treatment? Will one size fit all? And this is something I think that we are all working towards. Now, here's a fecal microbiome chip, which I used in a number of patients who are healthy controls, patients with Crohn's disease, and ulcerative colitis. This is a chip that we developed some years ago. So each of these is a single, each line is a single individual. These are controls, Crohn's, and UC. The red spots indicate where there is upregulation of certain bacterial genes. And you'll see in UC there's a major dysbiosis in this particular segment that we looked at between controls, patients with Crohn's and UC. In Crohn's, several other areas lit up, but it was not as consistent as we observed in UC. So the question then arises, and in fact, the reason we developed this chip was to be able to use it as an indicator of dysbiosis. So do we need to identify what kind of dysbiosis is going on in an individual before we intervene with a specific treatment? Possibly yes. Do we also need to genotype the host? In this case, here in inflammatory bowel disease, I certainly think we'll come to a time when we will need to genotype the host to understand what kind of organism is best used to treat the dysbiosis in these patients. And that may well work for other situations as well. So there are, and this is my last slide virtually, there are some issues in the management of dysbiosis. Currently, the diagnosis of dysbiosis is in its infancy. It requires sophisticated microbial analysis. Now, in every individual with a disease, dysbiosis is not necessarily associated with the same microbes. You see, healthy Indians and healthy Americans have totally different gut microbiota. So you cannot say that Indians are dysbiotic or Americans are dysbiotic just on that basis. So you need to understand what is different in each population. The other problem, the other challenge that we face when we try to intervene is that permanent change of the gut microbiome is virtually impossible with any of the current interventions. Now, people have been researching this for over 30 years. In the culture-dependent era, when probiotics were initially given, the moment you stop the probiotic and you wait for a week, you will find that you can no longer culture this from the stool. And now we understand this with any of the interventions that we use, whether it be probiotics, whether it be prebiotics, whether it be diet alone, or whether it be fecal microbiota transplant. You have to keep giving it for it to be permanently effective. So this is a challenge that we need to be able to understand and sum out. So with that, I will end and we'll go back to Dr. GC.
Fascinating. There have been, I think, almost 100 questions. So I don't know whether you will have time to address all of them, but I'll just sample a few of them and then, hopefully it will answer quite a few others. So let's start with one. Does giving a probiotic with antibiotic help? Straight question. The question is that, sometimes the antibiotic can kill the probiotic, or do you think that giving it with an antibiotic helps?
I assume I can answer that question, Gaurav?
Yes, please.
Yeah, all right. So, okay. So, most of the probiotics that we use are lactobacilli. there are certain antibiotics which come packaged with a probiotic. And the question is whether this is wrong. The answer is that most lactobacilli have intrinsic resistance to a number of antibiotics. They do not have the drug targets for those antibiotics. So it is perfectly rational in my mind to give an antibiotic with a probiotic.
Second question, I'll go a little quickly for some of the simple ones because there are some other complicated questions. If you are giving a probiotic, should it be before food or after food or with food?
Ideally, after food. Probiotics are actually expected to be acid resistant, to be bile resistant, and to be able to colonize the small bowel, ideally.
Okay.
But ideally after food.
Okay. Any of you, your thoughts on what about candida in the gut? Is it? I mean, you would call it a normal flora, or would you call it something abnormal?
Yeah, so that's a very interesting question, I would say. If you remember one of my initial slides, microbiota consists not only with bacteria but also virus and fungus. And in fact, fungus constitutes somewhat more than what the bacteria constitutes. So having some of the fungus would be good because, again, there will be lots of crosstalk in the functionality and the constitution of the microbiota. And fungus, again, if we talk about candida, there are many different candida varieties, and many of them are actually non-pathogenic and they reside as healthy commensals. And now with newer sequencing technology, even we have some data on the fungus in the gut, and many of the candida are actually non-pathogenic, and it could actually contribute to the
I'll provoke both of you a little further.
Of the
intestinal
system.
But Rama, I'm coming to you. The little different flavor of that same question. So a person comes with very difficult gut problem, call it IBS or whatever it is, gets a stool test done, and the report says yeast-like organism seen. Would you recommend treating it, or what would you think of doing?
I would definitely, that would depend on the clinical situation.
Yeah.
If it is an immunocompromised patient who's having symptoms, yes, I would treat it. If it is an otherwise healthy patient with what you said, which is symptoms of IBS, I would probably just give probiotics and try to normalize it.
I mean, if he was a normal patient, he wouldn't get a stool test done. So he has some symptoms.
I understand that. But, if he was very sick and he was immunocompromised, I would treat him.
You would treat him. Okay, fair enough. There's a very difficult question about your thoughts on linolenic acid.
All right. Yeah, to that addressed.
The anti-obesity activity of linolenic acid.
Okay. Yeah, you want me to take?
Anyone?
Yeah. So, yes, sir.
So linolenic acid.
Sir, you take up for
it. Give me a favorite of mine, so I'll let me answer a bit on that. So linolenic acid is an unsaturated long-chain fatty acid. Now, the thing with the linolenic acid is that it was originally thought to be one of the causes of tropical sprue because it did something to the gut bacterial flora and promoted the growth of coliforms in the small intestine. So if you look at tropical sprue in Puerto Rico and Haiti, it usually used to happen after feasting, which contained a lot of linolenic acid. So that is the background, possibly to overeating or on linolenic acid.
Okay, 2 or 3 other interesting questions. Your thoughts about Helicobacter pylori in the stool. I mean, do you think it can be a commensal, or does it have to be a pathogen?
Okay, yeah. So Helicobacter pylori is a commensal in the intestine, in the stomach, but it can become a pathogen based upon several factors. One of them is change in the other microbiota. So there are now elegant studies which have shown this clearly. by
Okay.
itself, Helicobacter is not necessarily
Another
a pathogen.
difficult
We can
question,
see it
I'm
as a
sure, from
commensal.
a good physician.
So again,
Role of probiotics in managing bronchial asthma.
Okay.
wow,
Right.
that's interesting.
So
Maybe sir can
there
take
is
up.
a lot of interest in probiotics and allergy. And this is particularly in relationship to skin allergies. So in Scandinavian countries, in fact, children are fed probiotics at birth to prevent their developing an allergogenic gut microbiome. What it does in bronchial asthma is, I don't think it has been well studied. So it could, bronchial asthma is a Th2 driven disease. So probiotics, by increasing T regulatory cells, may help, but I'm not aware that there have been any major studies which have looked at this.
Okay, another question very similar by another doctor. Any role of probiotics in treating autoimmune disorders? So when you say autoimmune, it doesn't necessarily have to be Th2, but I mean, what are your thoughts about autoimmune in general?
So the same thing applies here. So, there is this hygiene hypothesis which states that in the last 60 or 70 years, inflammatory diseases and autoimmune diseases have risen. And that includes both asthma, type 1 diabetes, multiple sclerosis, Crohn's disease, and a variety of other autoimmune diseases. And people have linked this with changes in our gut flora. So again, the issue is that there is Th1 immunity, there's Th2 immunity. And what is maintaining the balance are the T regulatory cells. And probiotics essentially increase the amount of T regulatory cells. So potentially, yes, they have a preventive role.
Okay, I'll come to two very fundamental questions at the end of these two talks. I'm not saying that's the end of the question session, but two very fundamental questions. How do you, in a clinical setting, diagnose dysbiosis?
Okay, so in a clinical setting, the only way to, I mean, it's just each disease, you think that there is a dysbiosis there. And in fact, practitioners of lifestyle medicine will go further and say that even normal or abnormal behavior is dependent on dysbiosis. So clinically, it's very hard to say to diagnose dysbiosis. I think you need.
So let me fine tune that question. Is the diagnosis of dysbiosis still in the realm of research, or has it come into the clinical practice that you can actually diagnose it by certain tests, or is it only to further our understanding of the whole process at this point?
Practitioners of lifestyle medicine do use a test for dysbiosis, very similar to the chip which I showed you. So, in fact, I am aware that these firms which are in the US have agents in India. They collect the stool and send it through special couriers to the West, where the microbiome is analyzed, and you get a 30-page report based on which they advise a variety of things. I think that's hocus pocus for now. It hasn't yet become a science. I certainly will not endorse it.
Yeah, I agree.
Yes.
So I think, can I comment? Yeah. So one thing, one of course, as sir has very aptly said, is difficult. But if the patient has some kind of symptoms, then you can imagine. Okay, suppose the patient comes with some bowel irregularity. So again, it's difficult to prove it. But in a real life clinical practice, we can just presume, okay, this patient could have dysbiosis. But again, this would be very presumptive, not very objective. And to confirm it objectively is really difficult, and it's time consuming, and it would be it may not be cost effective, even though sequencing services are there. Now many centers have come up even in India to do all this sequencing, but it may not be cost effective.
Okay. There's one very interesting, difficult question, but I'll just keep it for a little later after 3 questions. So let me finish 3 others. What's the link between the gut microbiota and diabetes and cancers?
Okay, so one is there has been several studies now, including one study from our center, where we could show that the microbiota changes in like type 1 diabetes, type 2 diabetes, and type 3C, pancreatogenic diabetes, they are different. But the problem is, it's very difficult to say it's a chicken or the egg. Is the microbiota changing because of diabetes, or actually it is causing diabetes? And in the context of chronic pancreatitis, what I would like to believe is it's a two-way process. For example, if I can talk about chronic pancreatitis, there would be pancreatic exocrine insufficiency. There will be lots of maldigested fat within the intestine. Fat can cause dysbiosis, and this we have actually published a couple of years back. When there is dysbiosis, that could further lead to disruption of the gut barrier, which leads to endotoxemia, and that endotoxemia can secondarily again cause beta cell dysfunction. So I think it's kind of a loop. Initially, it would be directed by the pancreatitis itself, and then there is dysbiosis, which can contribute to the diabetes. So this holds good for type 3C or pancreatogenic diabetes. In type 1 and type 2 diabetes, if we look at the microbial mechanism, again, coming back to linoleic acid disbalance, that has been shown, or that is known to cause or been associated with diabetes, or it in normal function, it is supposed to have anti-diabetogenic or anti-obesogenic effect. But again, it's difficult to say which is the chicken or the egg.
Rama, hold on. I've got more difficult questions.
If Ramo sir wants to add something.
Okay. Because I'm impressed. The number of questions, it's just flooded. And I think most of them are very, very interesting and very deep questions. It's really difficult to pass it off. We use rifaximin a good deal nowadays for GI disorders. How much does it distort the normal gut flora?
So rifaximin is actually one of the more effective drugs for dysbiosis in certain situations. Largely because it is not absorbed, and in terms of what it does to the flora, I think there's not been too many studies on what exactly it does, except that it suppresses certain. I'm not really sure, but clinically it has been shown. Other than its effect in IBS and in hepatic encephalopathy, it has also been suggested that it can be very useful in IBS because it specifically suppresses the bacteroidetes and certain other.
Okay, let me ask you a more simple, direct question, Rama. When we use other antibiotics, like say, for example, amoxicillin or what have you, we often have a little heavy heart that, we are actually creating havoc with the gut microflora. When we use rifaximin, do we have to think that way, or do we feel, well, it's really not that big a deal for the gut microbes?
The actual fact is, actually, we've also done these studies in the past, and it's been very difficult to get reproducible results as to what exactly it does to the gut flora, as to which specific classes it suppresses. And the reason is very simple. There is a huge inter-individual variability in the gut microbiome. So if you take 10 different people and look at their gut microbiota, there will be 10 different things that you'll see. So eventually, although we kind of take a population average, when you give rifaximin or when you give amoxicillin, as you said, it's very difficult to say that it specifically affects bacteria A, B, and C. But certainly with rifaximin, the disruption is much less than you would get with amoxicillin or with co-amoxiclav.
Okay. So, taking it on the same note, we prescribe proton pump inhibitors left and right. How does PPI alter the gut flora? And does it have clinical implications?
So the way PPI alters the gut flora is probably you get a migration of bacteria upwards. So it's more of small bowel bacterial overgrowth rather than any major effects on the fecal flora. The whole problem is whatever we are studying, we end up studying the fecal microbiota. That's why I talked a little bit about mucosal microbiota, which we need to study. We need to look at proximal gut, which we are somewhat hesitant to do because it's so invasive.
Right. Yeah. Yes. And there are studies, if I can come in, that proton pump inhibitor, besides causing migration of bacteria proximally and causing SIBO, it also has effect on the overall structure and composition of the bacteria by itself. So proton pump inhibitor does cause or dysbiosis.
Sorry, I've lost your... Hello.
Oh, sorry, can you... Yeah, sure. So is there a kind of a test like the chip that you showed in one of your slides, which can be used in clinical practice to say that, look, this gentleman has got an abnormal microflora?
Commercially available in India? No. I mean, we could easily develop that chip. Commercially available in the US, yes, it costs about 30 or 40,000 rupees if you do it from here.
Okay. One question from a young lady. What are your thoughts about the role of SIBO in fatty liver disease? Can the thin fat Indian phenotype or lean NASH be a product or at least a consequence to some extent of SIBO or altered gut flora?
So that idea has been around for about 30 years now, that fatty liver could be due to SIBO. I'm not aware that we have excellent proof of that. I mean, the whole problem is that there are so many other factors which now come in. Now we know, for instance, that toxins, which we are not even aware of, we are absorbing constantly. And so those might also be responsible for a certain amount of fatty liver. Can't hear you. I think you might have muted your microphone.
Again, sir.
Sorry, one question from Dr. Rakesh Kumar Tandon. I don't know if it's my teacher, Dr. Rakesh Kumar Tandon, or teacher. But, is there any evidence that administration of probiotics to healthy people may increase their immunity?
There is plenty of experimental evidence that administering probiotics to healthy people improves immunity. So many others. People have looked at interleukin production, secretory IgA production. Everything goes up. Definitely administering. So my own feeling is that probiotics have a place in healthy people. It certainly improves immunity, at least by laboratory parameters.
Any role of colostrum in dysbiosis?
Colostrum, yes, possibly, because colostrum has antibodies. It probably has galacto-oligosaccharides, which stimulate good bacteria. It will stimulate bifidobacteria and lactobacilli. I referred to the practice in some Scandinavian countries of giving probiotics immediately at the time of birth to steer the bacteria towards a normal type.
Would you give probiotics to people who have undergone an organ transplant?
I would really try to avoid it in people who have immunodeficiencies. That's because very rarely these lactobacilli and other bacteria can get into the bloodstream and cause bacteremia and septicemia.
There's one interesting question from Dr. Geeta. Is there any role of prophylaxis, of giving probiotic prophylaxis for COVID-19?
You're asking us to speculate?
No, since you are fielding all the difficult questions, Rupjyoti is giving a smug smile that he is escaping.
So we'll refer to Rup, I think. Yeah.
Go ahead, but I know difficult questions, but that's why Rama, you're there, and we are all there to listen.
So at this point of time, I don't think probiotics have. I don't know what relationship they have to COVID-19, but certainly COVID-19 you have too much of an immune response also, it's not too good. That's what we are hearing now. So I'm not sure that you really want to stimulate your immunity by adding to it with probiotics.
Okay, one very different question. Saccharomyces Boulardii, which is one of the constituents of many probiotics, it's not a normal gut microbe. Am I right? I mean, I didn't see it in most of your list, but it's a part of most of the probiotic preparations for many reasons that we know. Is it useful in managing dysbiosis?
Yes. So the general belief is that it is useful. All these are useful in managing dysbiosis. So why do we use microbes? All these microbes, they utilize certain nutrients which reach the colon, and they put out some metabolites which are used by other bacteria. And so these microbes, they talk to each other. There are lots of signals which go between microbial communities. So what we don't understand is exactly how this cooperation works. So on the whole, it does look as if certain yeasts are helpful. I mean, Saccharomyces Boulardii, Gaur, when we were kids, people used to give us Marmite and things like that, yeast. There was a yeast preparation. And that was supposed to be healthy. It keeps your gut healthy.
And I think Saccharomyces Boulardii or yeast-based probiotics have a little advantage because of its size. Like it's 10 times larger than a bacteria, so it can replace one yeast cell can replace 10 pathogenic bacteria, and it is more stable all throughout the intestine. It can resist a wide range of pH and other hostile environment of the intestine. So I think that gives a little advantage of Saccharomyces Boulardii over the other bacteria-based.
And certainly it's not killed by antibiotics.
Of the preparations have a combination of.
It's a very useful part of it. But anyway, one very interesting question: how important is Lactobacillus reuteri?
I guess what do you mean? How important is it? It's one of the probiotics that's available.
Do you think it has got a specific role, if at all, or how do you rate it as one of the constituents of a probiotic preparation and so on and so forth?
So currently, Lactobacillus reuteri is being promoted as something which kills Helicobacter pylori. So the claims are that in about 70% of patients, you can get rid of H. pylori by taking Lactobacillus reuteri maybe for 2 weeks or a month. I'm not very sure that that we have the evidence to prove that.
Okay, so I think if we have to answer all the questions, it will be midnight. It will be midnight. But you can understand the amount of enthusiasm that your talks have generated. Sure, to Rama.
Yeah. Can I ask a question, sir? Yeah. So, sir, when you select a probiotic preparation, so would you look at certain characteristics because there are so many in the market? I mean, almost every company has a probiotic now. So, would that be any guidelines for the
that was one of the questions,
like anything specific to be seen to select a probiotic?
Certainly, yes. I think when it comes to diarrhea, for instance, certain probiotics have definitely been shown to be very good. For instance, Lactobacillus GG. As just for instance, there are others. Lactobacillus reuteri, for instance. So in diarrhea, the single strain ones seem to do well.
Yeah.
In conditions which are characterized by inflammation, I think a consortium of strains is probably good. And this is why, for instance, inflammatory bowel disease, we had VSL3 performing very well. And so under those circumstances, a consortium is probably better.
What about radiation proctitis? Any role?
Not to my knowledge.
Okay. One other question is that which is the most studied evidence-based probiotic in India? Is there any that you can think of? Or you would rather not comment? whichever way.
Not comment, I think.
From India.
Okay.
Yeah.
And can obesity be controlled with probiotics in the future? Rupjyoti, you showed that very provocative slide when somebody was eating that huge burger, and you see that westernized food leads to obesity because the gut microbiota changes. Can you reverse it by just using certain types of probiotics?
Yeah. So right. So now there is ample convincing evidence. I'm using the word convincing because many of the evidence in the literature is really difficult to be convinced. But regarding obesity and microbes, both at animal levels, like experimental levels, and human studies, there have been convincing evidence that the microbiota could contribute to obesity. So there was a very beautiful study. I didn't show the slides because of lack of time. Like, it's an experimental study when fecal microbial transplant was done to a lean mouse from an obese patient. The mouse became obese. So that's kind of a conclusive evidence that if you have a obesogenic or microbiota, it can change. But I'm not sure that the currently available probiotics can do that. I mean, there are no strong evidence that actually the currently available probiotics can do. But in future, and people are thinking in those lines, if we can sample the organism microbiota in those particular patients, and then we can think of developing designer probiotics, specifically addressing it's very difficult, it's going to be difficult, but that could be an area. And now, in fact, personalized gut microbial manipulation is being tried in cancer treatment, like immunotherapy for melanoma, for instance. The treatment with PD-1, an immunotherapy agent, that the treatment can be altered by changing the gut microbiota. So I think this is potentially going to be a reality in the future.
Can I on a philosophical level
could stop
that question
obesity at this point?
Yeah. So the thing is, I think if you have inflammation in the gut, probably obesity will come down. So the issue is like this: if you have too much firmicutes, less bacteroidetes, you tend to become obese. So you have less firmicutes, you have more bacteroidetes. Possibly there will be inflammation in the gut, limiting absorption, and perhaps changing the gut hormones, which will make a person less obese. That's just a kind of
but you said that firmicutes are good and bacteroides are not too good, or shall we say bad, and that is how the balance is. So
but too much of a good thing is not good, right?
Yeah, that also you did mention.
Yeah, but so that was actually like when the microbiome biology was developing, that firmicutes are good, bacteroids, by and large, they can be considered good or bad. But what actually plays a role are the strains at the species level. Now, with more and more sequencing, we know more about the species and subspecies strains. And it is at that level where all this happens. So I think firmicutes as good or bad is more of a relative term than an absolute term. So what do you think, Ramos sir? I mean, that's
I agree. I think. But we are getting late, I guess.
Your opinion on that.
Two tough questions. Last two tough questions. First to Rupjyoti. Rupjyoti, you showed that there was tremendous amount of diversity in the gut flora, depending on from where the person hails, ethnicity, diet, and so on and so forth. Okay. Now, given that scenario, would it not be logical to think that each particular person coming from a background would have, so to say, a normal bacteriogram or a gut microbiogram, in the sense that, we tend to make everything so simplistic that normal should be for everybody. So what are your thoughts on that?
Yeah. Agree. I mean, so whatever we say normal, I mean, it's very difficult to put a rubber stamp. Okay, this is normal. Normal could be variable across populations, and as Rama sir has also said earlier, the American normal may not be the Indian normal. And if you see the last slide, there was lots of diversity even within the Indian north-south different parts of the country. So the most core organisms which is abundant highly in all population are Faecalibacterium prosnitzi and Prevotella copri. But then based on their genetic background and their socio-cultural background, there could be variations. So it would not be right to discount them as abnormal. So I think we should look at it in the context of
we have to have many normals, but we have to
clinical
define
scenario
it
or
and
their disease
individualize it to a large
biology.
extent, depending on the person.
Yes, and probably that is one of the reasons why conventional probiotics may not
if I
work
may
for all patients.
extrapolate,
said in one of the slides,
if you have a person who's on a vegan diet and he does not actually take meat products or milk, so then his gut microbiome is likely to be very different. On the other hand, if a person is a milk consumer, his gut flora would be different, and if a person is a meat consumer, gut flora is going to be different. Am I right?
Yes.
So we need different mammograms for people with different diets and backgrounds. I mean, in the future.
Different. Yeah.
Okay. So that brings me to the last very important question I would ask both of you, but Rama, obviously you're the one. You know, the present concept seems to be that every company has got one probiotic concoction. And it appears that, you know, for all maladies of the gut, that particular product would fit everybody with a GI disorder. I mean, do you think it works, or I mean, how would you look at that approach? Because I think it's a very highly individualistic situation, the gut microbiome, and we tend to actually have one fit all kind of a therapy approach.
Thank you for the tough one. Certainly, I think, as I alluded to it, I think single organisms have their place. They have their place in certain diseases. Consortia of organisms have their place in different diseases. And even there, as I said, it doesn't, one size doesn't fit all. So sometimes you do have, you cannot expect that a single organism will cure all the kinds of diseases which are there. So I think you need to be judicious in your choice of the probiotic for different kinds of diseases.
Excellent. Any parting comments from any of you before I wind up?
Agree.
I'm supposed to say that
it was an excellent session, and I'm really glad that there were so many questions, practical.
But let me on behalf of all the audience, tell you what an extraordinary delight it was to listen to the two of you. This is a time when everybody is all the time hooked to webinars on COVID. And the fact that, there have been so many people coming and listening to you and posting so many questions shows that if you have an expert who can talk about original research and convey the message, there are people who are willing to listen and learn from it. So, I mean, from my side and on behalf of all the audience, I can't thank you enough. Brilliant, excellent. And you really made my day. And keep it up. I'm so proud that, this is research coming from India. And two of you are the stalwarts in that area. Thank you.
Thank you.
Thank you so much.
Bye.
Thank you. Thank you so much, sir. Thank you. Thank you, sir. Bye.